Hello, good evening, everyone. Welcome back to My IVF Answers and the European Fertility Society. We are back. This is our second webinar this week, and I'm glad to be here with Dr. Antonio Urbano. You can see him right here. Hello, Dr. Urbano. Welcome back to our webinar platform. Welcome back to our patients. How are you feeling today? Thank you so much for joining us already.
Thank you, Caroline, for your invitation. I'm very happy to stay with you to talk about genetics, no?
Definitely. It's going to be an interesting session, no doubt here. And I also want to mention that Dr. Urbano is the clinical geneticist at UR Vistahermosa. And we have Christina from the international department here with us as well. Hi, Christina. Hello.
Hi.
Thank you so much for joining us as well.
Hello, all. Thank you very much.
Thank you so much indeed. Christina is here to support us as well. And of course, remember that we will start with Dr. Urbano's presentation first, but afterwards there will be time for your questions. So if you have any, I think you know already what to do, but of course, remember, you can put the questions in the chat section. Dr. Urbano definitely will be happy to help you out with any questions you might have. And there might be some questions, as we have a very, I would say, interesting, intriguing, but also difficult subject today, embryo aneuploidy. So to test or not, and when to test the embryo. So this is something that we will explore today. And this is your second webinar with us, Dr. Urbano. I'm glad that you are back with the subject that I know you like. This is the second most favorite subject. I remember you mentioned this. So thank you so much for bringing this for us today as well. And I think that we can go ahead and start with our presentation. And afterwards, we will go for the questions.
Okay.
You can start sharing your screen so we can see it.
Screen. Thank you, Caroline.
Thank you so much indeed.
I think that is not sorry.
So yes, now we can see it. Perfect. Thank you so much. Let's go ahead.
See anything, not a spoiler. Okay, thank you, Caroline. It's that Caroline said, I'm Antonio Urbano from Alicante, from UR Group International, and Numa Genetics. That is a new project that involved that it's a company for genetics test, and it's a pleasure for me to stay with you to talk about genetics. And today, like say Caroline, we're going to talk embryo aneuploidy and IVF, to test or not, and when to test. First of all, I want you to know that what is a normal chromosomally embryo, okay? For this, here we can see a karyotype, a male karyotype male karyotype. Karyotype is a photography of all chromosomes, okay? All it is distributed in 23 pairs, okay? From pair 1 to pair 22 are called autosomic, and it is the same in male and female. And the 23rd pair, it's called sexual chromosomes or sexual pair, and it is the difference between male and female. This is a male with X, chromosome X and chromosome Y, and it's the normal situation for a male with 46 chromosomes divided into 23 pairs. If we see the other situation, is the same, 22 pairs of autosomic chromosome, like the men, and a sexual chromosome with 2 chromosome X. There are 46 chromosome and 2 X chromosome. That is the normal female. Okay, but not always is there. Almost human being have 46 chromosome divided into 23 pairs of chromosome. That is the euploid. That is the first time we said this word, but this is the we talk about in the presentation. Okay, it's about euploids and aneuploid. Euploid means that is the normal situation when we have 46 chromosome XY or XX. Sometimes there is some kind of errors in the division of the cells, and like here we have 3 chromosomes in the pair 21, okay, that it's called trisomy, okay, trisomy, that you have 3 chromosomes in one pair, and not, you don't have 2, okay. This situation, when you have 47 chromosomes, it's an aneuploidy. It is a 47XX plus 21. That is this Down syndrome that you, I'm sure that you listened about it. If you have 18 chromosomes, it's called Edwards syndrome, or it's a trisomy, sorry, in the 13 chromosome, it's called Pateau syndrome. And that's, I say that syndrome because it's the most prevalent in the birth, at birth, sorry, or than are pregnant. In this situation, when you have one chromosome more or one chromosome less, it's called aneuploidy. Okay, and what's the problem with aneuploidy? Aneuploidy, it's the embryos with aneuploid don't have the potential to get pregnant. Okay, only when you have a trisomy 21, trisomy 18, or trisomy 13, or monosomy. Monosomy, when you have one chromosome less in the X chromosome, it's the only compatible with life. Okay. Other situation, if you have 1 chromosome 1 or 3 chromosome 1, 3 chromosome 8, this is not compatible with life, and it's developed to or finish with a pregnancy loss. Okay. Or if you are in IVF process, it will be securely it will be a pregnancy implantation failure. Okay. Well, now we know what is aneuploid means, and that's the second question is, how common is it? It's common. It's common in the human being. Okay, because actually it's really common. It's really common, and it's the relation is very tight with the women age. Okay, the probability to have an embryo aneuploid, an aneuploid embryo is bigger when the mother is older. Okay, we have different graphic that is how decrease fertility with years and increase miscarriage rate. Okay, that is I was talking just right now. And you have an aneuploid in one chromosome different from 13, 18, and 21, it will be a miscarriage. Okay, and obviously we have an increased prevalence of fetal aneuploid 13, 18, 21, and you have more probability that have a baby with one of this syndrome. If we center on the probability of have an aneuploid embryo, this curve tell us the probability. Okay, this is the probability that your embryos are aneuploid with the mother age. Okay, and the point that really changed things is about 38 years, and we call it advanced maternal age. Biological is only biological. Social, a woman or man with 38 years is a very young man or woman. Okay, it's only for fertility. Okay, and people with women with 38 have a probability of about 50% of an aneuploid embryo. But if the women have 42 or more, it's more than 80% of the embryo will be aneuploid. Okay, it's
Dr. Urbano, apologies. Can you try and share your screen once again? We cannot see your presentation at this point. I'm not sure what happened, but if you can just click, it's all right. We'll try.
That's only with the last slide?
Just now. It just happened right now. So.
Okay. Sorry, it was here.
Yeah, and now you can just put the full mode.
Right here.
Yeah, now we can see it. Sorry, yes, it's all working. Thank you.
Okay, thank you. I'm sorry. We have here 42 years. It's about 80% of your embryo will be aneuploid. Okay. Can we detect it? Yes, sure. But we have good news. Nowadays, we can detect all aneuploidies in the embryo before transfers it to the uterus. Okay, it is a standard protocol that used routinely in IVF clinics and genetics laboratory, and allows to select the euploid's embryo and discard aneuploids embryo to achieve better results in shorter times. Okay, this process is performed in. The first we do is like you see here, we have 3 very good quality embryos, very good quality day 5 embryo blastocysts called blastocysts. Okay, we can decide which of one we transfer first. Okay, that is exactly the same morphology quality. Okay, that we need another test to decide which of these embryos we transfer first. Okay, the first we do to test PGT-A is to perform or to do to biopsy the embryo. And the most common is this situation in day 5 or day 6. We take some cells from the trophectoderm. Trophectoderm is the tissue or are the cells that will form the placenta. Okay, it's not related with the baby. The baby is in another zone that is called inner cell mass. Okay, and we take 5 to 10 cells, okay, and we take it to the laboratory to do the next step. Okay, and the next step is a laboratory workflow, okay, which includes whole genome amplification. That is technically, if you want, later we can talk about this. That is technically, I think that all laboratories works very similar way. Okay, we take a library and we use the next generation sequencing. That is the very powerful tool in genomics, okay, in genetics or in genomics, that allows us apply bioinformatic analysis that based in the DNA that we extract from these trophectoderm cells, we can detect the number of chromosomes, okay? And the results are, we see here, okay? Results that embryo 1 is a really euploid embryo, okay? We see here it's a line, okay, where if the red line is in the center line, they have 2 copies for chromosome 1, chromosome 2 have 2 copies, etc., and 2 X chromosomes. Okay, this is a healthy female embryo. Okay, instead the number 2 and the number 3 are aneuploidy. Okay, it's have a 3 chromosome 22, and here we have 1 monosomy for chromosome 15. Okay, in this situation, if we take number 2, if we don't do a PGT-A, we can select number 2 for the first to prioritize, to transfer, and it's don't get pregnancy. Okay, because trisomy 22 it's incompatible with life. Okay, and the same with number 3. Okay, this is important because is how can benefit the PGT-A to couples. Okay, not only we don't have better probability pregnancy or better results in accumulate when we do all transfers. Okay, because we have 1. If I transfer number 3 first, we don't have pregnancy. Try with number 2, we don't have pregnancy, and try with number 1, yes, we have pregnancy. Okay, but you have to do 3 transfer to achieve pregnancy. Okay, but if we do PGT-A, we directly select number one and transfer it to the utero, and it's more probability that you achieve your healthy baby. Okay, and indication, what couples, what women specifically, or what couples will benefit with the PGT-A techniques. Okay, all scientific guidelines say us, or it's demonstrated. It's demonstrated that we have very benefits. We have better results in advanced maternal age. Okay, is the first indication for this technique. When you have more than 2 miscarriages, okay, this is recurrent pregnancy loss is the same. Okay, when you have 2 miscarriages previously, it's indicating, and when you have it's the same. When you have 2 implantation failure, you can benefit with PGT-A, and not only for women. If the male have an infertility with oligoastenoteratospermia, we have better results that we don't apply PGT-A. Okay, and let me show you some graphic. This is very illustrated about the use of PGT-A. Okay, and people say that PGT-A eliminates maternal age factor. Okay, that we can see here. Okay, in green we are seeing PGA's group, and in orange, no PGA's group. Okay, and we say that the probability to get implantation, or the implantation rate, is the same under 35 and plus 42. The average 67% in all different maternal age group. Okay, this is very important, and if we eliminate the maternal age rate, and if we see it in number, okay, that in this table, this work for Cam and Rubio, and we have, I can see, that's important only the live birth transfers. It's important the number of percentage of miscarriage in the PGT-A group. This work less than 3%. In the non-PGT, about 40% of miscarriage. Okay, and the live birth for transfer, okay, is about 65% versus or against 27.4% for non-PGT. I was talking recently about the pregnancy rate for patients. This is very similar, okay, because if you transfer all your embryos, you get pregnancy in the same way, but the time that you need to achieve these results are shorter when you do PGT-A versus not PGT-A. Okay, and the same is the for miscarriage rate. We eliminate the maternal age factor. Okay, group without PGT-A, group with PGT-A. Okay, let's see, because the first cases of miscarriage rate is because the embryo is aneuploidy. Okay, about 50% of miscarriage are due to this aneuploid. Okay, and okay, yes, I'm talking about this indication, but really, if we think that it helps us to select the best embryo, the embryo with the most probability to get a pregnancy, in not only a pregnancy, to get our objective, that is a healthy baby in your home, okay, it's better. You can use this PGT-A in all couples that want get this healthy baby in shorter time, okay, and in my career is always have the patient have the same doubt. Okay, they don't know what to do when they have only one good quality blastocyst, and this work help us to elucidate that in when we have only one good quality, it's a good idea to make a PGT-A, because the live birth for embryo transfer, when you do PGT-A, then when you have only one, one embryo, is about 50%. And if you don't do this PGT-A, it's about 30%. Okay. And what's next? Okay, this is a very powerful tool to get pregnancy, to get a healthy baby in your home. Okay, it's very good. That it's very technical. The process of biopsy is must be done by a very high professional, high quality professional. Okay, that maybe it's not present in all IVF centers. Okay, that's. Don't worry, because there is some genetic laboratory like NUMA that we can display, and we can go to every IVF center, do the biopsy, and take the sample to our laboratory to do the genetic process, the genetic workflow. Okay, this is no problem, but it's better if we don't touch the embryo. Okay, if the embryo don't suffer in any way. In our mind, we develop a non-invasive chromosome screening that we call secure select. That's only the thing is when you have your oocyte, you make ICSI. Okay, and you have your embryo development in one culture medium. Okay, to day 5 or to day 6. This embryo is sorry, I don't know the word. That is Cristina, help me. Expulsando DNA. No sé cómo.
So the liquid is expulsion.
I don't know.
Extracting, so
I think I can explain another way. The DNA present in the embryo will be present in the culture medium. Okay, and if we take it, if you know about NIPT, non-invasive prenatal test, it is the same method. Okay, that instead in the blood we use the culture medium where the blastocyst is. Okay, we use the same workflow in the laboratory, next generation sequencing, and we have the results. Okay, and this is very, very, very powerful, because we don't have in the same concordance rate than PGT-A. It is true, and this non-invasive secure select, for example, or another commercial names, there are no diagnostic tests, but they have a very, very good concordance. And I present this work. I don't want to bore you with technical papers, okay, that I don't want to say. I only want to see you that in this work, okay, the concordance in the culture medium against embryo was about 94%. Instead, the 12-octodem biopsy, that was 82%. Okay, this is only a work, and there are more than the concordance. It's variable, but I want to show you here that this technique is very, very good. Okay, and it's allow us not diagnostic the aneuploidy, but we have a very good biomarker to select euploid embryo without biopsy. Okay, and we have a range that the probability that your embryo with this technique, I think that is the first that you have to prioritize, you have to transfer to the utero, because I know that this embryo have a more than 85% probability to be euploid, and I don't realize any biopsy. We don't touch the embryo. Okay, this is a very good technique that we can use when you don't have indication of PGT-A. Okay, if you are a healthy when you are a young couple with a lot of embryo, you are a very good cycle with 5, 6, 7 good quality embryo. You will benefit with this technique because you, without the risk of the biopsy, this risk is very low value, okay, but it's a risk, okay. But if you do this technique, it's without any risk for the embryo, and we can prioritize the transfer of the more probability embryo, the more probability embryo to be euploid, to be the more probability to get pregnancy. Okay, and for at last, I want to give you some message to take home. Number one is PGT-A can detect and select euploid embryos. PGT-A allows women get pregnancy independently their age. It's the same that we can eliminate the women age problem. Okay, PGT-A allows couples achieve pregnancy in shorter times than without PGT-A. PGT-A is a good option in the case with one embryo cycles. Non-invasive PGT-A can detect embryo aneuploidy from culture medium, okay, without biopsy the embryo. And in non-invasive PGT-A allows prioritizing the most probably euploid embryo for transfer, reducing in this way the time to get pregnant. Okay, and that's all. Thank you for your attention. I want to present Alicante and our laboratory. This is only an image with my colleagues, and Numa Genetics and UR Genetic Group. This is the people working Red, Antonio Urbano, Isabel. Okay, and it's a pleasure, and I'm here to answer your question if I can. Thank you so much.
Thank you so much indeed for sharing and, of course, for your explanation. And now I believe we can go ahead with the questions. Thank you so much, Dr. Urbano. It was really interesting, and as always. So thanks so much indeed. And are you ready for the questions? There are some of those.
Yes, I think.
Brilliant. So let me show you the first question. So how can I ensure that the embryo testing is performed at a reputable and reliable lab?
Every laboratory that do the PGT-A are reputable and reliable. There is no a small number of laboratories that do this, and if they don't be reputable and reliable, they don't continue their career a lot of time, because if you don't know how the biopsy does, or you don't know do biopsies, or you don't know biopsy, you can't continue this career. Okay? I can see that every people I know in this field are reputable and reliable and constantly, continuously improve their skill in biopsy.
Yeah, so in fact, nothing to worry about, yeah? Okay, thank you so much indeed for this question. Let's have a look. Next question from Polona. Does estrogen priming before starting stimulation causes slower or delayed follicle growth?
Oh, I'm sorry, but this is very gynecologist question, and I don't have. I can answer, but I don't think that my answer is a good answer. I prefer that it's.
That's understandable. Yes, remember, Dr. Urbano is a clinical geneticist. Sorry. So, so this question is definitely more for a gynecologist. So we are happy to forward forward this. I can make a note of this just to make sure, and I think we can get in touch with Ulona and send this to the team at UR Vistahermosa. I'm sure they will be able to help.
Okay.
Right?
I can
Perfect.
ask my
Chris.
I'm sorry, Polona.
It's definitely okay. Let's have a look at this. So, what are the chances of a false positive or false negative result in embryo aneuploidy test?
A very, very good question. In embryo aneuploidy testing by PGT-A, I think that is the question. By PGT-A, the chance of false positive exists. It's not very. It's a very controversial topic because there are some groups that are against PGT-A that use these false positives to fight against PGT-A defenders. Okay, it's honestly there are false positives like in all tests that you can do, but the range for false positives are low, and the risk for false negative are very, very reduced. Okay, this is the positive predictive value, and negative predictive value is false positive is a little higher than false negativities. I don't know any PGT-A euploid that developed in 21 trisomy or something. Okay, false positive exists, but then the risk is, and I don't know and depends in every laboratory and in every IVF center. It's different, okay? But the number I can say is under 95% of the probability that you have a false positive, okay?
Okay. Thank you so much, for your question. How about can testing harm the embryos?
Can testing harm the embryo? If the biopsy is due for a experimental biopsy, then no, it's always it's a risk because you are taking some thing. I think Cristina, creo que harm es dañar, ¿no? Cristina, sorry, because harm is harm
is dañar, sí, sí.
Vale, sí, okay, vale. Yes. Sorry, about harm. Sorry. It's a risk, okay, and it's in relation with the quality of the embryo, okay. If the quality of the embryo is poor, okay, it's maybe more probability to harm the embryo, okay. But if the embryo is a good quality with a good growth factor, the biopsy it's due by an expert, there are very, very little chance that you have harm in the embryo.
Okay, thank you so much indeed for explaining. Next question is a bit of a longer question with some details, so let's have a look one by one. Okay, I'm 34, diagnosed with PCOS, have been trying for 6 years, last 2 years with IVF, 5 embryo transfers, never been pregnant, no implantation. I have unexplained infertility with tested karyotype, NK cells, whole endo trio test set, vitamins, minerals, thyroid. We also did a 3D scan on the endometrium, all within norm. My husband's spermiogram was good. Max method has been used. We have done 2 egg retrievals, each time using the same sperm that has been frozen at the beginning. We now have sent our remaining 5 frozen embryos for PGT-A before doing another transfer. In case they all come back as aneuploid, in your opinion, do we have a chance for better PGT-A result if we go for new egg retrieval, or should we move to egg embryo donation instead?
Okay, with this, with the antecedents, with the history, if you maybe all the 5 embryos will be aneuploid, that it's explained because you can't get a pregnancy, okay? Because it's a difficult decision that you have to talk about with your gynecologist, but maybe it's the moment to think in egg donor, okay? I will. Before go to egg donor, I will do the PGT-A, and maybe if we have one euploid embryo, okay, will transfer it, and if maybe you can get the pregnancy with the euploid embryo, okay, but you probably are better than if you don't do the PGT-A. And if you do a PGT-A and result all 5 embryo and euploid, it is a diagnosis for you. Okay, you don't have good news, but you know why you don't get your pregnant. Okay, that's nowadays we can't make health embryos. Okay, we can't curar. We can't use some technology to rescue the trisomy or an embryo. Okay, but we
Exactly.
can watch what happened in this embryo, and with you have all the tests. All the tests are good, including endon, that is receptivity endometry, and endometrial receptivity. And if you have one euploid embryo, I think that you have very much probabilities that before you test. Okay, I think, and to just think of 5 embryo transfer, I think that's you maybe do PGT-A before, but okay, I think this is a good idea. Do the PGT-A for these 5 embryos, and if you don't achieve your results, maybe talk with your gynecologist and thinking about embryo X donation, because your husband is a good seminogram. No, spermiogram was good. I think that egg donation. I think it's a good idea.
So yeah, so basically all depends on the PGT-A results. Yes. So if
Yeah,
there is at
yeah,
least one euploid embryo, it's a go. If not, maybe it's better to consider egg
yeah.
donation or embryo transfer, of
Well,
course.
5 MBA transfer, it's a lot of transfer.
Exactly. Just because there were already 5 transfers here.
Okay.
Okay. Thank you so much indeed for sharing. Hope that was useful for you. And of course, as always, best of luck. And yeah, thank you so much indeed for
Thank you.
joining us. And let's have a look. Another question here. I have only one blastocyst, grade 5BA. It is a double donation, egg donor age 28. I have transferred an embryo of 5AA last year, same donor, with implantation failure. I would like to test genetically my last embryo to see if it is euploid, but my doctor considered this not necessary because of the age of my donor, 28. What do you think about that? Some recommendations.
I think if we remember that the graphic I put in, I show you, there is about 30% to 35% that a woman with 20 years old have an aneuploid embryo. Okay, this is the probability is in here. The human being is very bad in reproduction ways. We can't. It's very difficult for the human achieve naturally a pregnant. Okay, only 20% of the relationship without protection will finish in a pregnancy. Okay, and I think that you have only one. I want to. I don't want to. I don't want to say my thoughts. I want to talk you with data, with scientific data, okay? And I show you that it's benefit for couples with only one embryo, because if you test this embryo and this employee, okay, go on. I don't mind if she have 28 years, because you have about 35-40% of have an aneuploid embryo, okay? And if you test and it's euploid, okay, sorry, aneuploid, don't transfer it and try again, okay? And I think that I think that is a good recommendation to PGT-A, because you have implantation failure previously. Okay, I think that is a good idea.
Okay, so PGT-A in such case, as long as it is euploid embryo, go on. If it's not, then it's better to repeat.
I want to base my answer in scientific
Of course.
data. Okay, I think that's. I'm very. I think honestly that PGT-A can help or can benefit all couples. Okay, because you can shorten your time to get pregnancy. Okay? You can avoid transfer that it will be nothing because the embryo is an embryo. Don't mind if you have 28 for 31. Okay, you are young. Your probability to have an aneuploidy embryo is 30%, 40%. Okay, but it's there. You have if the economy is no problem, I do it.
Of course.
Okay, it's.
Believe that was clear enough. Of course, Sylvia, if you have any follow-ups, go ahead. But I would like to say that Martin, previous patient, would like to thank you for your answer already. And let's have a look at the next question. So I have low AMH, but the reason we are going with ICSI is due to male fertility issues. I asked our doctor about PGT-A, and he said it was not needed because I am relatively young, about to turn 36, and would not make sense given the low level of blastocysts we are likely to get. Is there a general recommendation for patients with low AMH?
I say when I was talking that it's a recurrent question because PGT-A is indicate for advanced maternal age or antimullerian or low antimullerian. That means that you have 1, 2, 3 blastocysts in the better cases. Okay, and it's. Can we do the PGT-A? I think yes. Again, okay, because I think that you have an information that is very, very important. It's the I will do because it's the most powerful tool that we have to select embryos. There is no another tool to select the embryo, the correct embryo. Morphology don't detect euploid embryos. Okay, morphokinetics don't detect embryo, and the euploid embryo. That's not all, but it's a very, very important thing in the equation that you have to have a pregnancy. Okay, maybe you transfer a euploid embryo and don't get pregnancy. Okay, but I assure you. I can assure you. I can te puedo asegurar. I can assure. Sí,
Assure you.
I assure you. Thank you. I assure you that if you transfer an euploid embryo, your chances are 0. Okay, this is very important. That not all, but very important. It's very important that you have an euploid embryo to transfer. Okay, and for low antimulleriana or for only 1 or 2 blastocyst cycles, I show you that if you PGT in that word, in the group with PGT-A have I don't remember 56% of pregnancy rate. If you don't, you have a 26 pregnancy rate. Okay, it's relative. We have to play with the risk, with the probability, with the statistic. Okay, and I think it's a good idea. Okay, it's my opinion.
Thank you so much. And actually, there is a follow-up. I will show you from the very same patient. Sorry, here. So thank you. Also felt it would be a good idea and was surprised our doctor did not think it would make sense. Maybe he thought it was a cost issue, which we would be happy to pay. I will go back to them. Thanks again, most helpful.
Okay.
Thank you so much, Daphne, for your comment here as well. And best of luck as always. And of course, let's have a look. Probably our final question. So if you have any, this will be the final call for those questions. And the question is from Hannah. Does aneuploidy have any relation to ectopic pregnancy? As in, does transferring an aneuploid increase the chance of having an ectopic?
No, because the aneuploid embryo don't pregnancy, so don't get to the pregnancy. This is really that there is one type of aneuploid embryo that is in relation with ectopic pregnancy. That it's called, in Spanish it's called mola. In English I don't know. I think that is the mola iletoforme. That I don't know if it's the same name, but not really. Not really the aneuploid embryo. Is not relation with the topic, salvo instead that this specific type of embryo. Okay, I don't know if I can explain that. It's difficult for me to explain because I don't know the number. The number in Spanish is mola. That is an embryo that is an egg without chromosome load to get an individual. So to get
morula stage.
no morula. No, it's not morula. It's another thing. I don't know. I'm sorry, Hannah, but
molar pregnancy.
Molar pregnancy, yes, molar pregnancy is causes because one specific type of aneuploidy in embryo, but a monosomy of chromosome 2 in an embryo is not related with ectopic embryo. Okay. Pregnancy, sorry.
So yeah, so it's not related, definitely. Oh, sorry, this is not what I wanted to show. Yeah, here.
Okay.
I think I lost it. So yeah, this is here. Sorry. Yeah, so because this is like a comment, right? So I want to test it, but the Greek law does not allow it. Yeah, this is from our previous patient. In this case, I could risk to transfer a aneuploid embryo or leave it. Is it in Spain the same?
In Spain, is allowed to get to do PGT-A. I think that.
Let me just show you because I missed this. So basically, the patient says that the Greek law doesn't allow to test donated embryo because they considered it is not necessary.
Donated embryo.
Yes,
Okay,
and here's the follow-up.
We can, yes, in Spain it's allowed. Okay, but I think I don't know if the law forbid to do the biopsy because non-invasive is a very good option in countries that PGT-A or biopsy is forbidden because you don't touch the embryo. Okay, and that is a very, I don't know, you can, if in Greek the law forbid touch embryos from donors, you can do an IPGT-A. It is a very good option. Okay.
And can you tell us a little bit more on that? Because of course this is still a new method, I believe, non-invasive PGT-A. This is what you're talking about, right?
Yes, it is. It's a very, very powerful tool. I think that is better than PGT-A because you don't touch the embryo, okay, and you have a more complete representation of DNA. I don't talk about mosaic things. That is, I think that is a webinar only for this thing, for this topic, for mosaics in embryos, okay, and this is because when you do the biopsy, you took 5 or 10 cells. You are don't watching or you are don't test every or whole embryo. Okay, in the non-invasive PGT-A, the DNA are from every cell of the embryo. Okay, because for this. I have the image of the work of hand that show the concordance with the whole embryo with the media is better than embryo versus trophoctoderm. It's for this reason, because in the culture media you have the representation of potentially all cells of the embryo. Okay, and it's very good. It's really that actually it's not diagnostic, okay, but only it's question of time. Okay, it's question of time because don't have a lot of data to compare. Okay, it's not always the same because before we have NGS, we have array CTH. Before this, we have fish, and we have to validate a little bit. It's important. It's important that scientific work will support these results. Okay, but we are working with this technique. We are very happy with the results, and we want to present this in some congress in the next year, because Esre just happened the last week, and I think that is the future. I think in 1 year, 2 years, maybe it's the PGT-A. It will replace with the nursing vaccine. This is my opinion. Okay,
of course.
It's a very good technique.
Thank you so much for clarifying. We've done some webinars on non-invasive PGT-A as well, so it's good to hear that it's progressing and you are working on this, and we are looking forward to some more new data to confirm its availability, of course, right? So thank you so much, definitely. And as I've mentioned, it seems that was our final question. So thanks everyone for joining. Thank you for your questions. And as you can see, some comments are right here. Thank you very much for the information. Very valuable. Couldn't agree more, for sure. And thank you so much indeed, Dr. Urbano. And before we finish, anything else you wish to add?
I want to thank you. I only want to say thank you for you. Thank you for listening to me. I expect that I'm not very bored.
Definitely not.
My English teacher said that I have a very strong accent. I said, I'm sorry, I'm Spanish. I can't modify my accent. I only want to.
We understand everything. I think everyone will agree with me here. So thank you so much. Everything was understandable, and thank you so much indeed, everyone as well. Dr. Urbano, it's been great to have you. And as you can see, more comments are coming up. Look forward to see other interesting webinars. Thank you so much indeed. We will be back for sure. Christina, thank you also for your support, and I just want to mention that we will be back with some more events soon, and actually next week on Tuesday we will talk about PGT-A indication and prospects with Dr. Angela Janeta from a different clinic, Clinica Chambers. I hope you will be able to join us as well. It's going to be an interesting session, I'm sure. So thank you everyone for joining. This has been recorded, so if you missed any parts, you will have a chance to watch this again tomorrow. Our a special guest for today, geneticist, this time geneticist from UR Vistahermosa, Dr. Antonio Urbano and Christina from their international department, those were our guest speakers. Thank you so much for joining. Have a lovely evening, everyone, and hope to see you both soon. Okay?
Thank you, Caroline.
Thank you.
Thank you. Thank you very much.
Take care. Bye.
Bye-bye.
Bye.